Screening for co-occurring disorders is particularly important. Here are some of the most predominant common co-occurring disorders that I see: ADHD, PTSD, NPD, BPD, OCPD. That's a big one. OCPD is the most prominent in the general population while simultaneously being the most underdiagnosed. So there are a lot of people out there with OCPD who don't know it, and they're getting treatments that aren't addressing a pretty big, important factor, right? And I would recommend RODBT, radically open DBT, if you're working with that. But their acting out behaviors are going to look very different if they've got OCPD. They're going to be way on that over-controlled side biotemperamentally. Always question the label of treatment resistance. I get a lot of people who come in and I'm the 9th person they've seen, and I call their former therapist and they say, oh, they're very treatment resistant. I don't like that term. Probably there's something else in the mix that hasn't yet been discovered. We want to be really curious, and I am very open with clients about this. Hey, if you've had 8 false starts, maybe there's something else going on. Maybe it's not you. And this is not just important for the treatment of the individual clients, but for the coupleship and for the partners, because a lot of times what happens in my work, especially if there is sex addiction going on, then, okay, so here's this man or woman or, this person who's going and they're doing 12-step and they're doing all this kind of stuff. And then here's the betrayed partner or spouse, and they're going to their support groups and they do what we call compare and despair, right? They hear of the progress of the other, of the partners of the people in their group, and their partner isn't making the same progress. They need to know if there are co-occurring disorders going on so we can set their expectations appropriately. Otherwise, they'll get stuck in compare and despair.